Hi, my name is Brian. I'm a current PGY1 pharmacy resident at Champlain Valley Physicians Hospital, part of the University of Vermont Health Network. Today I'll be discussing the topic of rate versus rhythm control in atrial fibrillation. Specifically, we'll take a look at the recently published EAST-AFNET IV Trial and discuss some of its clinical implications as far as managing patients with atrial fibrillation. We'll first start by discussing some pertinent recommendations from both the 2014 and 2019 focused update from the AHA-ACC-HRS guideline for the management of patients with atrial fibrillation. We'll review some key findings from a landmark clinical trial that evaluated rate versus rhythm control in atrial fibrillation, which was the Affirm Trial. And then lastly, we'll finish off by discussing the methodology results, limitations, as well as clinical implications of the recently published EAST-AFNET IV Trial. To start, I have a quick self-assessment question for you. According to the AHA-ACC-HRS 2014 guideline for the management of atrial fibrillation, what is the target resting heart rate for symptomatic atrial fibrillation? Is it A, less than 80 beats per minute, B, less than 90 beats per minute, C, less than 100 beats per minute, or D, less than 110 beats per minute? If you want to take a second and pause the slideshow here, consider how you'll answer that. We'll go over the answer on the next slide. On the next slide, we'll take a look at some of the recommendations surrounding rate control in atrial fibrillation. And as you'll see, the correct answer for this question is going to be a target resting heart rate of less than 80 beats per minute. Just as a sort of review and overview of rate control in general, I've included from the 2014 guidelines a summary of all the recommendations surrounding rate control in atrial fibrillation, as you can see on the right there. Just some key considerations to discuss. So rate control agents that we use, primarily beta blockers and your non-dihydropyridine calcium channel blockers like verapamil and diltiazem are going to be your heavy hitters for that. Amiodarone is typically reserved for refractory cases, given its side effect profile. Digoxin is not directly recommended as a first-line agent, but it may be used in practice, and you may see that being used for rate control. As far as your target resting heart rates, so for symptomatic management of atrial fibrillation, as we discussed with our review question, a target resting heart rate of less than 80 beats per minute is recommended. But in our patients who are asymptomatic with preserved left ventricular ejection fraction, the guidelines recommend using a more lenient rate control strategy, targeting a higher heart rate of less than 110 beats per minute may be reasonable. And then there is also a recommendation for AV nodal ablation included in the guidelines. AV nodal ablation can be considered a reasonable option when pharmacological therapy is inadequate and rhythm control is not achievable. This diagram comes directly from the guidelines as well. It just gives you a general overview of the approach to rate control and selection of rate control agent depending on comorbidities. As you can see, like I discussed, your beta blockers and your non-dihydropyridine calcium channel blockers really are going to be your first-line agents. Amiodarone, again, because of its side effect profile, we really want to reserve that as much as we can for patients who are unable to achieve adequate rate control with these first-line agents. The other option we have for managing our patients with atrial fibrillation is a rhythm control strategy. So when we think about a rhythm control strategy, there's three main strategies that we can consider. One being cardioversion, whether it be electrical or pharmacological. The second would be antiarrhythmic drugs to maintain sinus rhythm. And then lastly, we have catheter ablation as an option. The most compelling indication for pursuing a rhythm control strategy is if a patient has persistent symptoms that are associated with atrial fibrillation. The guidelines also have a list of some factors to consider where a rhythm control strategy may be favorable for a given patient. So things like difficulty achieving rate control. Younger patients may have better outcomes with a rhythm control strategy versus older patients if they have tachycardia mediated cardiomyopathy, or a first episode of AFib, or AFib that is precipitated by an acute illness. A rhythm control strategy may be preferred. And then if patients prefer to pursue a rhythm control strategy, that's also another consideration. When we use antiarrhythmic drugs as a rhythm control strategy, we typically use them to reduce the frequency and duration of atrial fibrillation and to improve quality of life. Really, studies have shown that the efficacy of antiarrhythmic drugs for this purpose is pretty modest. Another thing to consider is that a rhythm control strategy should not result in the cessation of antithrombotic therapy and proper rate control therapy. So all these things should be utilized together to manage these patients with atrial fibrillation if we are pursuing a rhythm control strategy. Guidelines also recommend before initiating antiarrhythmic therapy, if there is a precipitating or reversible cause of atrial fibrillation, to ensure that we're treating that first. And then guideline recommended drugs to maintain sinus rhythm in patients with AFib include amiodarone, dofetilide, dronedarone, flecainide, propafenone, and sotalol are your recommended antiarrhythmic drugs. The 2019 focused update to the 2014 guidelines also included a new recommendation regarding catheter ablation. So as you can see listed down below there, catheter ablation can now be considered for symptomatic atrial fibrillation patients who have heart failure with reduced ejection fraction to potentially lower mortality rate as well as reduce hospitalization for heart failure. So this comes from some new evidence that has emerged since the publication of the 2014 guidelines. Historically, there's been sort of this debate as to what the most optimal strategy is to pursue for managing our patients with atrial fibrillation. Randomized controlled trials have failed to demonstrate any superiority of maintaining a rhythm control strategy versus a rate control strategy on outcomes such as mortality in patients with atrial fibrillation. In addition, there's also some evidence to show that for candidates of both rate and rhythm control, using a rhythm control strategy actually results in more hospitalizations for these patients. Another thing to consider is that up until recently, catheter ablation has not been studied compared to rate control strategies. So we don't really know how that plays into practice and managing these patients. So with that being said, I wanted to revisit one of the landmark clinical trials that has sort of informed the debate regarding rhythm versus rate control in atrial fibrillation, and that's going to be the Affirm trial. The Affirm trial was the first and the largest trial to directly compare a rate control strategy with a rhythm control strategy in patients with AFib. It was published back in 2002, and many of the recommendations that we have today surrounding rate control and rhythm control in these patients stems directly from what they found with the Affirm trial. So it's definitely been a landmark trial in that regard. With that, we'll talk about some of the methodology and key findings from the Affirm trial and discuss how it informed future practice. This was a multi-center parallel group randomized controlled trial that included patients who were 65 years and older or those who had risk factors for stroke or death with atrial fibrillation that was deemed likely to be recurrent and likely to cause illness or death. Under the discretion of the enrolling physician, long-term treatment of their atrial fibrillation was determined to be warranted. Patients were excluded if they had any contraindication to anticoagulant therapy or if they were ineligible to undergo trials of at least 2 drugs in either of the treatment strategies. Again, the intervention was a rate control strategy versus a rhythm control strategy. Their primary outcome was all-cause mortality, and their secondary outcome of interest was a composite that included death, disabling stroke, disabling anoxic encephalopathy, major bleeding, and cardiac arrest. The rate control strategy entailed a target resting heart rate of less than 80 beats per minute and a heart rate of less than 110 beats per minute during activity. Rate control agents included beta blockers, your 9-dihydropyridine calcium channel blockers, as well as digoxin up to the discretion of the treating physician. Patients in the rate control strategy were also continuously anticoagulated with warfarin with a goal INR of 2 to 3. In the rhythm control strategy, patients were treated with antiarrhythmic agents chosen by the treating physician, as well as cardioversion as necessary to maintain sinus rhythm. Antiarrhythmic drugs that were used included quinidine, procainamide, disopyramide, flecainide, propafenone, amiodarone, and sotalol, dofetilide, and morphine. Anticoagulation with warfarin, again with a goal INR to 2 to 3, was encouraged. However, unlike the rate control strategy who received continuous anticoag, those in the rhythm control strategy could stop their anticoagulation if sinus rhythm was maintained for at least 4 weeks, although they did specify ideally for 12 consecutive weeks. And then lastly, radiofrequency ablation, maze procedures, and pacing techniques could be considered after at least 2 trials of a rate or rhythm control drug. So patients in either group could undergo these non-pharmacological options if warranted. So Affirm was a pretty large trial enrolling over 4,000 patients. Looking at the patient population, the mean age was 70 years. About a quarter of the patients had a history of heart failure. Looking at predominant cardiac diagnoses, half of the patients had hypertension, about a quarter had coronary artery disease, and then 5% of patients had valvular and vascular disease. About 1/3 of the patients, this was their first episode of atrial fibrillation. At baseline, there weren't any significant differences between the two groups, and they were pretty well matched. With regard to the primary outcome, which again was all-cause mortality, that they assessed at 5-year follow-up period, they found that there were numerically more deaths in the rhythm control group than there were in the rate control group. But looking at the p-value and the confidence interval, we can see that this was not a statistically significant association, although there was a definite trend towards increased mortality with the rhythm control strategy. So we can see this depicted on the graph on the right. There was a divergence between the two groups at about 1.5 to 2 years, and this divergence remained through the 5-year follow-up period. They also conducted several pre-specified subgroup analysis with regard to the primary outcome of all-cause mortality. They found a significant association with rhythm control with a higher risk of death compared to rate control, specifically among patients who were older than 65 years old, those without congestive heart failure, and those who had coronary artery disease. And you can see these depicted there on the forest plot on the right. Here in this table, we can see what agents were used for rate control and for rhythm control in both treatment groups, both for initial treatment as well as at any point during the treatment course. Of note, it's not included on this table here, but the usage of warfarin was significantly lower in the rhythm control group when compared to the rate control group. And again, this will be attributed to the fact that those in the rhythm control group were able to discontinue their anticoagulation after at least 4 weeks of maintaining normal sinus rhythm. For the secondary composite outcome of death, disabling stroke, disabling anoxic encephalopathy, major bleeding, and cardiac arrest, there was no difference between the rate and the rhythm control groups for this outcome. There was a significantly higher incidence of torsades seen with the rhythm control group compared to the rate control group. For those who experienced cardiac arrest followed by resuscitation in either group, there was a significantly higher incidence of PEA, bradycardia, or other rhythms in the rhythm control group compared to the rate control group. In addition, looking at hospitalizations after baseline, there's a significantly higher incidence of hospitalizations seen with the rhythm control group versus the rate control group. We can see there was 80% hospitalizations in the rhythm control group versus 73% had hospitalizations after baseline in the rate control group. The Affirm trial does have several limitations, one being a potential selection bias in that patients who had frequent or severe symptoms may have been considered unsuitable for a rate control strategy by their treating physician, and therefore these patients may not have been enrolled in the study. There was also a limitation on external validity in the fact that we can't really generalize these results to younger patients who didn't have risk factors for stroke. Specifically, this plays into those patients who have paroxysmal AFib that essentially resolves on its own. There was also a high prevalence of sinus rhythm in both groups, regardless of treatment. And then lastly, there was also the concern with anticoagulation, how that was handled in the trial. Again, those in the rhythm control group could actually discontinue their warfarin if they had maintained sinus rhythm for at least 4 weeks. So this actually led to a significantly lower usage of warfarin in that group, and this may have introduced a bias in as far as the stroke and the death outcomes, given that there was actually less use of anticoagulation in the rhythm control group. Thinking about the clinical implications of Affirm, so as I mentioned, Affirm was the first and the largest study to compare rate and rhythm control strategies for treating AFib. They didn't find a statistically significant difference in mortality between the groups at 5 years, although they did find a non-significant trend towards increased mortality with the rhythm control strategy versus the rate control strategy. In addition, when they looked at secondary outcomes, the rhythm control strategy was also associated with significantly more hospitalizations compared to rate control. And with that being said, our current guidelines to date still cite Affirm in that increased risk in mortality and that increased risk in hospitalizations in their recommendations for using an initial rate control strategy in the majority of patients, only considering rhythm control if rate control is inadequate for treating patients' symptoms of atrial fibrillation. Now, having the context of the Affirm trial and what they found in that trial and how it informed clinical practice moving forward from then, now I want to move into discussing the recently published EAST-AFNET IV trial, or the early rhythm control therapy in patients with atrial fibrillation. This was published back in October of 2020 in the New England Journal of Medicine. This was an international parallel group randomized open blinded outcome assessment trial. They included patients who were 18 years or older who had early atrial fibrillation, which was defined as having a diagnosed 12 months or less prior to enrollment. They had to be greater than 75 years of age with previous TIA or stroke, or they had met two of the following criteria, being age greater than 65 years, female, heart failure, hypertension, diabetes, severe coronary artery disease, CKD, or left ventricular hypertrophy. Patients were excluded if they had a life expectancy of less than 1 year, any substance use disorder or prior atrial fibrillation procedure, which included ablation or surgery. Patients were excluded if they had a prosthetic mitral valve or severe mitral valve stenosis, any clinically relevant hepatic, thyroid, or renal dysfunction. These patients were also excluded. Again, the intervention here was an early rhythm control strategy compared to usual care. There were two different primary outcomes that they looked at. The first was a composite of death from cardiovascular causes, stroke, either ischemic or hemorrhagic, or hospitalizations with worsening of heart failure or acute coronary syndrome. The second primary outcome was number of nights spent in the hospital per year. As far as secondary outcomes, they looked at each component of the first primary outcome. They looked at rhythm, left ventricular function, quality of life, atrial fibrillation related symptoms, as well as cognitive function, all of these outcomes which they assessed at 2 years. The safety outcome of interest was a composite, again, of death from any cause, stroke, or pre-specified serious adverse events of interest, which captured complications of rhythm control therapy. Looking at the interventions that were used in the EAST-AFNET IV trial, those patients that were randomized to the early rhythm control group were treated with antirhythmic drugs or atrial fibrillation ablation, and were allowed to undergo cardioversion of any persistent atrial fibrillation. These treatments were initiated early after randomization, and then these patients were also treated with rate control that was chosen based upon local protocols and current guidelines. In the usual care group, patients were initially treated with a rate control strategy without any rhythm control, and then only if there was any uncontrolled atrial fibrillation related symptoms during adequate rate control, a rhythm control strategy could then be pursued in the usual care group. Similar to the Affirm trial, the EAST-AFNET IV trial was another large trial that enrolled close to 2,800 patients, 1,400 of whom were randomized to either early rhythm control or usual care. These patients had a mean age of 70 years old. Median days since AF diagnosis was 36 days. More than a third of these patients were experiencing their first episode of atrial fibrillation. About 30% of them were asymptomatic when it comes to their atrial fibrillation symptoms. The mean CHA2DS2 VAS score was 3.4 for both of the groups. About 90% of patients were on anticoagulation. And then when looking at the usual care group compared to early rhythm control, probably due to the randomization of the group, the usual care group, more patients were taking beta blockers and digoxin, which makes sense given that these patients were initially managed with a rate control strategy, and fewer patients were also taking statins. Here we can see the distribution of the different rhythm control strategies that were utilized between the treatment groups, both initially and after 2 years of follow-up. On the left side, we have early rhythm control group, and on the right side, we have usual care group. If we look at early rhythm control, we can see initially 8% of patients had underwent ablation. The remainder were on antiarrhythmic drugs, the most common being flecainide, amiodarone, and dronedarone. After about 2 years, the number of patients that underwent ablation increased up to 20%. Also of note, after 2 years, about 35% of patients were actually no longer receiving any rhythm control strategy. If we take a look now on the right side, looking at usual care, no one in usual care was initially managed with atrial fibrillation ablation. We can see by 2 years, about 7% had undergone ablation, and about 5% were actually receiving antiarrhythmic drugs. So now we'll take a look at our primary outcomes. Again, we had 2 different primary outcomes in the study. The first being a composite of death from cardiovascular causes, stroke, or hospitalizations with either worsening of heart failure or acute coronary syndrome. What they found was that this composite outcome had occurred less often in patients assigned to early rhythm control than in patients who are assigned to usual care. You can see the accompanying hazard ratio of 0.79, the 96% confidence interval, and the p-value listed there as well. When you look at the specific components of the composite primary outcome, we can see that death from cardiovascular causes and stroke had occurred significantly fewer times in the early rhythm control group compared to the usual care group. There was no difference in hospitalizations with worsening of heart failure or hospitalizations with acute coronary syndrome between the 2 groups. When we look at the second primary outcome, which was nights spent in the hospital, they did find no difference between the early rhythm control group or the usual care group. This figure now just depicts the first primary outcome, which again was that composite outcome of death from cardiovascular causes, stroke, or hospitalization with either worsening of heart failure or acute coronary syndrome. We can see there was a divergence between the 2 groups at about 1 year, with the early rhythm control group having a lower incidence of that primary composite outcome. Moving on now to secondary outcomes, at 2 years, there was no any evidence of a significant between-group difference for left ventricular function, quality of life, atrial fibrillation-related symptoms, or cognitive function. Looking now at some of the safety outcomes, for the primary safety outcome, which was the composite of death from any cause, stroke, or serious adverse events related to rhythm control therapy, they found no difference between groups for this composite outcome. When you break it down and look at the specific components of the composite outcome, however, stroke had occurred less frequently among early rhythm control group when compared to the usual care group. Additionally, as expected, the incidence of serious adverse events was higher in the rhythm control group compared to the usual care group over the 5-year follow-up period. The EAST-AFNET IV trial does not come without its limitations, however, one being the open-label trial design, which may have introduced some investigator bias. However, the assessment of the primary outcomes was actually blinded, so that may have minimized any bias in that regard. One of the most significant limitations, in my opinion, was that the trial was not specifically designed to assess either the safety or efficacy of any specific component of early rhythm control, whether that have been a specific antiarrhythmic agent or atrial fibrillation ablation. We don't really know how these stack up against each other, or whether or not any one specific component had driven the outcomes that we saw. Additionally, they only enrolled patients with early atrial fibrillation, so there's some limitations with the generalizability and the external validity that we cannot generalize these results to patients in whom rhythm control may be indicated later on in their treatment course. Similar to the Affirm trial as well, all of the patients that were enrolled in this trial were deemed eligible for either rate or rhythm control, so this likely may have excluded some of the most symptomatic patients from enrollment. And lastly, the EAST-AFNET IV trial, they did not collect any detailed data on recurrent atrial fibrillation. So when you actually look at the percentage of patients who were in sinus rhythm, the results are really not comparable to patients in other trials because they did not readily keep up on this information. So what can we take away from this? So essentially the EAST-AFNET IV trial showed us that rhythm control in patients with early atrial fibrillation was associated with a lower risk from death from cardiovascular causes, stroke, or hospitalization for heart failure or acute coronary syndrome compared to usual care over more than a 5-year follow-up period. We also saw that early rhythm control was not associated with an increased number of nights spent in the hospital, according to the second primary outcome that we saw in the study. This is an important finding in that when we look back at the Affirm trial, we remember that there was an increased incidence of hospitalization with rhythm control compared to rate control. So this is an interesting finding in that it shows us that there may not be that increased risk that we had initially thought with early rhythm control in these patients. We also learned that both rate control and rhythm control can both be used to effectively manage symptoms as well as maintain cardiac function in patients who have early atrial fibrillation. And this was seen specifically in the secondary outcome of left ventricular function. We saw that there was no difference in these groups with regard to left ventricular function. The inclusion of ablation in the early rhythm control group may have also contributed to the superiority that we saw of the early rhythm control group in this trial. In the Affirm trial, there was really a very, very low incidence of atrial fibrillation ablation that was utilized in either of the groups. So it would be interesting to see in the future if further studies go on to sort of delve into this topic a little bit more and sort of tease out if there's any additional benefit from atrial fibrillation ablation in these patients specifically. And lastly, in this trial, early rhythm control was associated with more adverse events related to therapy compared to usual care, which is not something that is surprising. Same as goes with the Affirm trial, we expect that there's more side effects, more adverse effects associated with rhythm control compared to our rate control strategies. To summarize what we discussed today, historically, there really isn't much evidence to support using a rhythm control strategy over a rate control strategy in patients with AFib. In fact, when we look at some of our landmark trials regarding the issue of rate versus rhythm control, such as Affirm, a rhythm control strategy actually has been associated with potentially worse outcomes, such as increased mortality risk, increased hospitalizations, and increased incidence of adverse events associated with rhythm control treatments. So as such, our current guidelines, which again, 2019 being the most recent iteration, still recommend that initial rate control strategy for most patients with atrial fibrillation and still emphasize utilizing a rhythm control strategy in patients whom remain symptomatic despite appropriate rate control. The EAST-AFNET IV trial that was published recently is an important clinical trial in that it demonstrated some clinical benefit with an early rhythm control strategy that included atrial fibrillation ablation in patients who had early atrial fibrillation. So again, those patients who were diagnosed less than 12 months and initiated early on a rhythm control strategy had some improved outcomes, such as reduced incidence of stroke and death from cardiovascular causes. So it'll be interesting to see in the next iteration of the guidelines how they actually implement the findings from EAST-AFNET IV and how it will inform their recommendations and kind of alter practice moving forward. That will conclude my discussion today on revisiting rate versus rhythm control in atrial fibrillation. I want to thank you guys for joining me today. If you do have any questions, comments, or concerns, please do feel free to reach out to me and I'll get back to you as soon as I can. You can leave a comment down below, or if you would like to email me, my email is listed on the first slide of the presentation.